right? So.
Yeah, nope, 5:30.
Oh, well, I'll get out of here now then. Just Judy coming?
No, just me. It's on train number.
Yeah.
Should I leave?
It's up to you. As long as you don't talk, it wouldn't matter. I'm in. Yeah, they just carried the class on live. That's all.
Oh, Lisa Leonard's not joining us tonight because her husband got called into work again. She's like, I really need to get to class. But she's watching it online.
But I told my husband I would feel better coming to the actual class in Brunswick. He's like, you're really going to go that far? I'm like, oh yeah, I am.
Well, how far is it
Send
for
me
you?
the address.
Or how far is it for you?
I'm outside of Gardner about another 40 minutes. So about an hour and 20 minutes or so to get there.
Okay. Well, we can also set up time to do a chat on the weekend too if you want.
Yep, that would work. It's
Okay.
I get as far as the 3 breakdowns, and I don't know how to count, like the history and the HPI, and that's where it's throwing me from there out. I understand the medical record and what's in it and where things belong. It picks up all the paper noises on their end.
Yeah, you can just mute. Just don't talk about me. I'll have to put a spell on you. All right.
I think mentally I'm past that point.
So welcome to, where are we, week 12? Yes. Week 12. There's no eraser. Week 12 of medical billing and coding.
Is that spray bottle for the board right there?
I hope so. Me too. Oh, thank goodness. All right. So week 12, medical billing and coding. We are on chapter 15. And chapter 15 is all about evaluation and management services. So what are evaluation and management services? They are simply when you go to the doctor and you go in with a complaint, a chief complaint. What's a chief complaint? The reason that you're there. Okay? And so there's one whole chapter about evaluation and management. So that's a lot of complaints. But we're dealing with the different types of complaints. We have inpatient, we have outpatient, we have rest home, and the various levels of E&Ms, the factors of E&Ms, and we'll get into all of that as we move forward. Now, last week we talked a little bit about tabbing your books, and that would be tabbing your CPT book. And this is what your CPT book looks like. And I have not had a chance to tab my new one, but the tabs, like I showed you last week, this is what they look like, okay? Maybe before, at the end of class, I'll take a picture of it and then just put it up on Evolve underneath the chapter for this week so you can see how I tab, okay? So maybe at the end of class you can just help me hold it and I can take a picture with my cell phone. Yeah, yeah. And then I got notification today that HCPCS, some are still on back order, some are still being sent. So if you haven't received it, it's not a problem. I'll go back and touch upon HCPCS again in some of the coding and just remind me, okay? Because some of you are going to have a HCPCS book like this. Some of you might end up getting a HCPCS book that looks like this, okay? And some of you might end up with a HCPCS book that looks like this. And what I mean, what it looks like that, it might be spiral bound, it might be the short chubby one, or it might be something like this, and it will say HCPCS across it. All right. So the whiteboard, when we get to using the whiteboard, I'll zoom in a little bit more so that we'll all be able to see it. We're actually going to do how a claim would look when we do E&M services. And we'll write it out on the board so you can understand what we're talking about. Week 12, right? There we go. We'll keep the blue one. We know the blue one works. Okay, so we got a couple that work. So, coding for services. We're going to be on page 427 in your textbook. And I want you to turn in your CPT book to the beginning of the E&M section. And I want you to, again, pay attention to the table of contents. And also to white space, okay? Because when I talk about white space, I want you to use the white space in your books, just like I did in the ICD-9 book, okay? Right underneath the table of contents, you have white space. Use it, okay? Remember how I mentioned early on in the class, when you're making notes, make the notes in your CPT book, all right? You can follow along in the textbook, but make sure that where we are in the textbook is where you are in the CPT book, so that you're making your notes, you're underlining, you're highlighting, all right in there. Pay attention to your service guidelines. All right, so your E&M services guidelines. They start on page 4.
Sorry, I had to get a highlighter. What
Okay.
page did you say?
Page 4 in your CPT book.
Okay.
So when you're coding for services, your job is to code what is documented in the medical record. All right? So your job is to optimize, never maximize, because optimize means to get the most out of. Maximize means to increase or make as great as possible. What we're looking to do is accurately report the documented services. It is a crime to code for services that are not provided. Fraud is billing for services that are never rendered. So what you will find in Chapter 15 will be the E&M section, so the evaluation and management. What this does is it reports the physician services. So when I start on, I'll tell you. The E&M service, it's divided into broad categories such as office visits, hospital visits, and consultations. And then most of your categories are further divided into 2 or more subcategories of E&M services. So for new and established patient, there are 2 subcategories such as initial and subsequent. So, you will have subsections by the type of service, and the types of service that you will see are office, hospital, and consultations. So, you might want to just make a note to yourself on page 4. Maybe right across the top, types of service, hospital, office, and consultations.
You said office, hospital.
and consultations. And then we have 3 factors. And I'm assuming everyone can hear me okay because I'm not yelling tonight. All right, the 3 factors are place of service, type of service, and patient status. So if you look at the bottom, at the first paragraph underneath classification of E&M services, the last sentence, this classification is important because the nature of work varies by type of service, place of service, and the patient status. So right on page 4 in your guidelines, first paragraph, last sentence. Highlight it. This is where we don't necessarily need to be writing stuff as much as we should be underlining or highlighting. And it's whatever works for you. If it makes more sense to highlight it, then highlight it. So, what is the place of service? The place of service explains the setting of the service. So that could be office, emergency department, nursing home, your type of service will be the physician's services. And we know that the physician provides many types of services. So that could be office visits, admissions, consultations, and prolonged services. The patient status. You have 4 types of those, and we'll get into them further. But the 4 status types are new patient, established patient, outpatient, and inpatient. What is a new patient? So, second column in your guidelines. Okay? A new patient is someone who has not received any professional services in the last 3 years. And that would be 3 years from the same physician or from another physician of the exact same specialty and subspecialty in the same group. New patients are more labor intensive for the physician and the staff. And why do you think that is?
All the paperwork.
Right, all of the paperwork, all of that intake paperwork. An established patient, and again, all of this is right in the guidelines, so you should be able to follow along right in the guidelines and highlight it, okay, on page 4 in your CPT book. An established patient is someone who has received professional services in the last 3 years from the same physician or another physician of the exact same specialty and subspecialty in the same group. So if you have a primary care practice that you go to, and there are 7 different practitioners in that office, and they are all family physicians, okay? Just let's say your primary care is Dr. Smith, but you call to get in one day and Dr. Smith isn't available. And you just can't wait to see Dr. Smith, so you make an appointment with a nurse practitioner. you are considered an established patient because someone from that same specialty is seeing you. Okay? And also what this means is that the medical record is available with current relevant information. So what is an outpatient? An outpatient is someone who has not been formally admitted to the healthcare facility. So when you go to your ear, nose, and throat doctor, when you go to your dentist, when you go to your chiropractor, when you go to a podiatrist, those are all outpatient services, okay? So a patient would receive service at a clinic or a same-day surgery center. And if a patient is admitted to observation status, that is considered outpatient. Inpatient is someone who has been formally admitted to a healthcare facility, such as a hospital or nursing facility. The attending physician would dictate admission orders, H&P, which is a history and physical, and request consultations. An attending physician would dictate admission orders, H&P, and request consultations. So the levels of E&M service are based on a couple different things. Now, in your book, in your CPT book, you're going to find a lot of coding tips. I want you to make sure you read those, okay? So levels of E&M service, over on page 6. Your levels of E&M service are based on, first of all, the nature of the presenting problem. So what is the foundation? Okay? And then we have the skill that is provided, or the skill that is required to provide the service. And then the time spent, if 50% of the total time is counseling or coordination of care. And then what is the level of knowledge necessary to treat the patient? And then what is the effort required and assumed? So you'll find that over in the right-hand column on page 6, top of the column, the levels of E&M services encompass the wide variations in skill, effort, time, responsibility, and medical knowledge required for the prevention or diagnosis and treatment of illness or injury and the promotion of optimal health. That says it perfectly right there. Then we have the E&M levels divided based on your key components and your contributory factors. Still right there on page 6. Every encounter will contain a varying amount of your key components and your contributing factors. Your encounters you'll see more of each component and factor. And with that, when you see more, it means that it's a higher level of service. When you see less of each component and factor, then it means you have a lower level of service. Your key components are the history, the exam, the medical decision making. All right, so put some brackets around history, exam, and medical decision making and indicate that those are your key components. Right there in your CPT book. History, exam, and medical decision making are the three key components. And then take and put a bracket around the contributory factors. And that would be your counseling, your coordination of care, and the nature of the presenting problem, and the time. Then we have 4 elements of a history. The 4 elements of a history starts off with a chief complaint. So you might want to turn back to page 5. After the chief complaint, we have the history of the present illness, which is the HPI. So your chief complaint is a CC, your HPI is the history of present illness. Then we have a review of systems, which is an ROS. And then we have a past, family, and social history, which is a PFSH. So
Could you repeat the one before the past history? I didn't catch that one. Kind of bleeped out.
Past, family, and or social history is PFSH.
Okay. Thanks.
Yep. So we should be on page 5 in your guidelines. All right, so the chief complaint is the subjective. And as I said earlier, what is the subjective? The subjective is what is the patient's own words. We put it in the patient's own words. So it's the reason for the encounter, the patient's current complaint. And it's usually presented, as I said, in the patient's own words. It is documented in the medical record for each encounter, and it is required for all levels of service. And it can be stated as CC, but it is inferred from the documentation that this is the chief complaint. The HPI, or History of Present Illness, over on page 6, is a description of the development of the current illness. So what is the date of onset? All right, so we have a chief complaint. We're going to keep it simple and say low back pain. All right, and then what's the history of the present illness? So what's the date of onset? say 1 week. It might say onset, it might say date of injury, it might say when it happened, okay? The patient would describe the history of the present illness. If they cannot answer for themselves, a parent, guardian, or other may provide. So low back pain started 1 week ago, shoveling driveway. Now, honestly, you're going to expand on that. You're going to put in the patient's words. Patient expresses or explains or states that they were shoveling the driveway, and when they bent down and threw snow to the right, they felt and heard a pop in their low back on the right side. Okay? That's how you're going to put it. Now, there are 8 elements in the HPI, and the provider must document them. So this is where the physician and the patient dialogue comes in. And they actually, through the book, give you an example of abdominal pain. So in your textbook, I think they go through a whole chief complaints and key components, review a system. They go through a dialogue. Let me see here. Okay, so they don't actually have it in the book, but we'll improvise. All right, so I gave you low back. So basically, it started on Thursday night. It was mild. During the night, it got worse. Friday morning, I went to work, but I had to leave because the pain got so bad. Okay, so I was shoveling. I lifted the snow. I twisted and turned and bent over, and then it was kind of mild, but when I woke up Friday morning, it was worse. All right, so then where is the location? Okay, so specific location of the pain, right side. Right side, low back. Above the buttocks. Okay? So the pain is in the lower right-hand side, a little toward the back. And they might even show you, right over here. And you can indicate in the paperwork when you do the exam, the consultation. So what is the quality of the pain? Is it sharp? Is it dull? Is there pressure? Is there burning? So the patient would explain, well, it's really sharp and constant. Okay. What is the severity? Is the pain intense, moderate, mild? So on a scale of 1 to 10, it may be stated. Pain is terrible, worst pain I've ever had. That's the intensity. How long has it been present? That's where I said a week ago. Okay. What is the timing? Is it present all the time, or does it come and go? Well, it just continues. It just doesn't go away. So then we want to ask, when does it hurt the most? So we want to correlate it to a specific activity. The pain is just there. It doesn't matter what I'm doing. So what we would indicate then is that the patient expresses that activities of daily living, okay, make it worse. So does anything make it better? No, nothing. Nothing I do makes it any better or any worse. How about aspirin? If you take aspirin or Aleve, no relief. Do you use ice? Do you use heat? You know, when you're moving, when you're resting, that type of stuff. Do you have any other signs and symptoms that are relating to the problem? So does anything else feel different when the pain is present? Okay. Yes, sometimes I have nausea when the pain is really bad. All right, so then this is where we get into the review of systems. Okay. So I know I went through those pretty slow, but if you can think back to a time when you were in your doctor's office, they ask you those questions all the time. We just thought about it as same old, same old. We never paid attention to why they were asking those questions. So then, you know, the nurse asks you, the front desk person asks you, the doctor asks you. So you wonder why in the heck you're having to repeat it 3 times. Now, you don't have to repeat it that much anymore, but early on it was like, don't you guys talk to one another? So with the EHR, it makes it a little easier because it's already there. So what the doctor's doing when the doctor comes in now is they are reviewing what you told the nurse, and then they're putting their digital signature on it that they reviewed everything with you. So now what has added to this whole intake process is height, weight, and blood pressure. Now we know they did it before, but it's even more important now. And they probably ask you if you smoke, if you drink, how much, how often, how long, okay? This is also part of the meaningful use, if you've heard of meaningful use. And I think we mentioned it early on in the course. So in a review of systems, we have organ systems. And under the organ systems, you'll see respiratory and cardiovascular. And what you will find is that there are 14 elements in the review of systems. So on page 433 in your textbook, and on page 7 and 8 in your guidelines for E&M. All right, there are 14 elements, and page 433 explains it really well. So the extent of the report of systems depends on the chief complaint. So for this low back pain, you might review constitutional, you might review genitourinary, you might review digestive, for a chest pain complaint, you might not review a musculoskeletal, but for a low back pain, you would. A patient who has sustained trauma from an auto accident and can't discern the difference, you might have to do a full workup. Okay, you might have to do the eyes, the ears, the cardiovascular, the genitourinary, the respiratory. Okay, pay attention to the chief complaint and see what system it relates to. Okay, that is how you're going to know. That's how you're going to get your level of service. Okay, your level of service is based on a bunch of things. But if I come in for low back pain, you're not going to charge the insurance a 99203 or an 04 or an 05. Those are really high level service E&M codes. you're probably going to only use a 99201 or 99211 because those are problem focused. What is problem focused? It means literally problem focused. I am going to focus just on your low back. That's it. So the medical necessity for the number of organ systems inventory must be implied or documented in your notes. So as I was mentioning earlier, some of the systems, constitutional, what is constitutional? It's general. It's fever, weight loss or gain. So if someone has low back pain, depending on how long they've had it, they might be having weight loss because they're just so uncomfortable. They don't want to eat because they're just in so much pain. Or if someone is in so much pain and they're an eater when they are in pain, they might gain weight. Earache, sore throat, you might have a fever. You might just feel fatigued. Your eyes. Your eyes actually are an organ system. Your ear, nose, and throat. Those are an organ system. The cardiovascular organ system. What's respiratory? Organ system. Gastrointestinal organ, genitourinary, musculoskeletal, integumentary. These are all organ systems. Neurological, psychiatric, endocrine, hematologic and lymphatic, and allergic and immunologic. These are all organ systems. Over on page 434, past family and or social history. Now your past and social history will contain relevant information about the past. So what have you had for major illnesses and injuries? Now it used to be that they wanted everything from your childhood. They don't want that anymore.
Oops, she disappeared.
I did. It's that magic that I use. So it used to be that they wanted your history from when you were a child. So let's see. I had my tonsils out. I had a bronchoscopy. I've had my vaccinations. I've had my tetanus shots. I had C-section. I had, any major surgeries. I haven't broken anything. I sliced a few things, but nothing got cut off. They want to know everything. Operations, hospitalizations, allergies. What are you allergic to? Okay. Medication, environmental, immunizations. Are you up to date on your immunizations? And then dietary status. Okay. Are you on a certain diet? Do you have celiac? Are you gluten intolerant or lactose intolerant or whatever it is? Okay, they ask you about past and social history. Now, we don't think about these things as being important because for us, it's an everyday occurrence. Okay, but if they don't understand what has happened in your life, then they can't take care of you appropriately. So if someone has an allergy to sulfur, the last thing
That's-
you want to do is give them a medication with sulfur in it.
That's
Because then
me,
they'll
and
have
that's
an
what they
allergic
did.
reaction.
A big allergic reaction. I mean, I dropped. Everything swelled up. Couldn't breathe. Nothing.
That's not good.
No.
So these are why they ask these questions. Your social history. Your social history contains relevant information about sexual history and other relevant factors such as employment, and then past and present medications. Now, you probably ask, why your sexual history? Well, because if you have been, for women, promiscuous, then they want to know if you might have some type of sexually transmitted disease or AIDS, okay? And then for men, if they're just out whoring around, they can get away with it, right? But they want to know. They want to know, have they had multiple sexual encounters where there have been instances of those types of things, so that they know how to treat them if it is something that is still in, current, or if it's just a past history. Okay, this is all history. Past and present medications. Okay, so, depression, nerve medication, migraine medication, acid reflux medication, whatever it is. Okay, past and present. Social tobacco and alcohol use. Well, are you an occasional drinker, an occasional smoker, a pack-a-day smoker, 6-pack-a-day drinker, bottle a night? What is it? Because all these things relate and add up to, is your liver going to fail? Or is your heart having a problem? But then that leads us into the health status of your family members. Now, I'm going to be dating myself here, but growing up, they used to ask you, and they still do, but not as deep. They still ask, who in your family has ever had blah, blah, blah? So they ask you, what are your current health problems? But then they also list a whole bunch of other health problems, and they say, who in your family has had these? So parents, siblings, and children. So it used to be that you would list your parents, high blood pressure, heart-related issues, cholesterol, cancer. And then you would go to your grandparents and say, alcoholic and depression and cardiovascular. And they used to actually go that far. But now it's just you, your children, and your parents. Doesn't seem like much, but I think our generation and maybe your generation is doing better than people before us. They used to have a big long list. Yeah. So your family history items are related to the chief complaint. So we know that if someone comes in with, let's just pick the two most prominent ones always are cholesterol and blood pressure. Okay? So we know that people who usually have high blood pressure, they say that it is hereditary. Well, guess what? That's a bunch of bull cookies. There is a part in us, in our DNA, that has that little tiny bit of history that says, yes, my family history is such that, but you can either own into it and follow that path, or you can decide that you're going to be the a chink in the chain that's going to break that cycle. Okay? I think I'm probably like in the middle where my older family members have that mindset where that's just the way it is. That's my DNA, that's my blood, that's how things are going to be, that's how I'm going to be, I'm going to just die that way. And they get on every medication in the book, and they're happy with it. But then they wonder what in the heck is going on when they're taking like 10 and 12 medications and they don't know why nothing's getting better.
Lifestyle.
Right, life sucks, I'm taking too many medications, I'm so tired all the time, my tummy's upset. Well, look at those 12 medications you're taking. Look at all the contraindications that those 12 medications have. You feel fatigued, you have upset stomach, you have blurry vision, vomiting, diarrhea, the list goes on of the side effects. And then you have, I want to say like from my age group down, where we have become aware that there is not only medicine, but there is alternative. So you'll see that people are putting more and more money out there to do the alternative. So they're being more active. They're looking at what is actually in their foods. And they're paying attention to how processed it is versus, grass-fed or non-GMOs or what have you. Okay? And so people can decide to break that hereditary link. But this is where that history, that family history, does or can relate to that chief complaint. So my husband has high blood pressure. Actually, it's kind of even right now, but he has high cholesterol. And the only reason he has high cholesterol is because his triglycerides were off the charts. But it is a family trait. So we looked, and sure enough, his other 5 siblings and his parents always would have high triglycerides. So we decided we didn't want to go the medication route. There had to be alternatives. So sure enough, he found some alternatives, some homeopathics, and he brought down his cholesterol from over 300 down to under 200 in 1 year. Just by changing the way we ate. He started going to the gym in the last 3 months and paying attention to what we put in our body. Now, the triglycerides were the ones that were really high. He got those down to normal. Those were off the charts. His HDL and LDL are now within normal limits. Those weren't even normal. They were crazy. So he made a conscious decision and effort to say, I'm not going on medication. So when he went a year ago, his doctor said the next step is medication if you cannot get this under control. We talked about it and we looked, but his family members and his mom are all on medication. So he has just increased his life expectancy by being able to do that. So, family history can play an important part, but you also don't have to buy into the fact that it is hereditary. It's still important to bring that family history into the E&M, because once it's in your chart, the doctor will say, okay, I know that you have a family member, 2 family members that always had high blood pressure. One died of cardiovascular incident, the other one's on medication. It helps them to know how they can help you. But it doesn't mean you, the patient, have to buy into that. So then we get into the history levels. There are 4 history levels. There's problem focused. There is expanded problem focused. And these are all right in your guidelines. It's on levels of E&M services. History levels, let's see. History levels. Page 9. Page 9 in the guidelines, your history levels. Problem focused, expanded problem focused, detailed, and comprehensive. Those are the 4. So the first one, being problem focused, is simply what I told you on the board, low back pain. It's a brief history focused on the chief complaint. So low back pain, when did it happen? You don't even have to do a review of systems. You might, and if you do, that's fine. You don't have to do a past family social history. Okay? It doesn't matter that my father had back pain, my mother had back pain. That is not hereditary. And then a little brief history that includes maybe 1 to 3 of the 8 elements of the history and personal injury. Your expanded problem-focused history is where there's a brief history focused on the chief complaint. You have less than 3 of the 8 elements, or 1 to 2 chronic problems. A review of systems as it pertains to the presenting problem. And then no past family social history. Your detailed history is where you do an extended history. An extended HPI. In the HPI, you would have 4 or more of the 8 elements. 3 or more chronic conditions. And then an extended report of review of systems. So detailed history. Let's say an elderly patient comes in. They're complaining of low back pain, acid reflux, constipation, arthritis, and some ringing in the ears. Well, we have 3 or more chronic conditions right there. Arthritis, ringing in the ears, and what else? Constipation. So we want to do an extended review of systems, right? And then we would want to make sure that we got pertinent past family and social history. So maybe what did they do for work? Comprehensive history is an extended history or an extended HPI. We would have a complete review of systems, a complete past family social history. So then in your book you have a figure 15.4 that shows you the summary of elements that are required for each level of history. And as you see in the beginning of your E&M section in your CPT book, they give you charts for the different types of E&Ms. Now, moving on to exams. For your exams, you also have 4 levels. And these are usually hands-on. This is where the doctor comes in and really takes a look at you. So problem-focused, expanded problem-focused, detailed, and comprehensive. The problem-focused exam is limited to the affected body and or organ system. So it could be low back or it could be kidneys. Based on the 1995 guidelines, you have 10 body areas and 12 organ systems. And I believe they have these in your textbook. I just don't remember what page. Alright, can find them later. Your expanded problem-focused exam is a limited exam. It's usually the affected body, organ, or organ system, any other related body and organ systems, such as your vitals and general appearance of the patient. You know, patient looks yellow or gray. A detailed examination is an extended exam of the affected body or organ system. Comprehensive exam on page 438, a complete single specialty or complete multi-system exam. And on figure 15-5, they give you the 4 different levels of elements required for each exam. So you want to remember that the extent of the exam depends on the needs of the patient and the expert judgment of that physician. So if it isn't documented, it didn't happen. And it may have happened, but you can't bill for it unless you documented it. So don't document the fact that actually, what I want to say is, don't give the patient a Band-Aid and then bill for it, but don't have it in your documentation. Okay? That's just wrong. And remember, the extent of the examination must be documented in the medical record. Medical decision making on 441. The level of your medical decision making is significantly different for a chest cold versus severe chest pain. Okay? There are 3 elements. Number 1 would be the number of diagnoses or management options. So you might have minimal, limited, moderate, or extensive. 2, the amount and or complexity of data to be reviewed by the physician. Again, is it minimal, limited, moderate, or extensive? What are the risk of complications or death? So morbidity or mortality, minimal, low, moderate, or high. There are 4 levels of medical decision-making complexity. You have straightforward, low, moderate, and high. Your straightforward is usually just the number of diagnoses or the management options, which are usually minimal. The amount and the complexity of the data is minimal or none, and the risk of complications to death is minimal. Your low complexity, the number of diagnoses or management options are limited, the amount and complexity of the data is limited, and the risk of complications or death are low. Moderate complexity, the number of diagnoses or management options are multiple. The amount and complexity of data is moderate. And the risk of complications or death is moderate. The high complexity, the number of diagnoses or management options is extensive. The amount and or complexity of data is extensive, and the risk of complications of death is usually high. So what are your management options? Your management options are based on the number of possible diagnoses, definitive or differential, and or the various ways that they can be treated. The data that is reviewed and ordered, it might be things like laboratory, radiology, test and procedure results that should be documented in the medical record. Usually a review of the results are documented in the medical record, so hemoglobin within normal limits, chest x-ray negative. Your old medical records or data from others may be requested and reviewed. When we talk about risks, we're talking about risks of morbidity, such as poor outcome or complications or mortality with problem and or treatment. Other diseases or factors that affect risks, diabetes would be a risk, extreme age would be a risk. Any urgency relating to risks, such as a myocardial infarction, a ruptured appendix. And then you have 4 risk levels. The first one would be minimal. The second one would be low, moderate, and then high. Your minimal is self-limited. So what do I mean by self-limited? It means that it might be a wasp bite or an insect bite. Low would be several minimal levels or one level that is more than minimal, so multiple insect bites. Moderate is usually 1 or more chronic illnesses, such as diabetes, 2 or more stable but chronic illnesses, someone with controlled high blood pressure and diabetes. Your moderate risk level. Your moderate risk level is undiagnosed condition with an unknown prognosis, such as a breast lump or an acute illness. Someone with pneumonia, that could be moderate. High, when we talk about a high risk level, this is someone who has 1 or more chronic illnesses with current severe exacerbation. So think of someone who has a malignant hypertension and uncontrolled diabetes. An illness or injury that is life-threatening, such as the myocardial infarction or cardiac arrest, that would be a high risk level. So on page 444 in your textbook, that gives you a summary of the elements required for each level of medical decision making, okay? A review of the 3 key components. This would be history, exam, and medical decision making. The first key component is the history, which we talked about earlier, is the chief complaint, the HPI, the report of or review of systems, and the past family social history. And then we have...
Sorry, could you tell me what page you're reading that on?
I'm not.
Oh, okay. I'm like, I don't see
On
it.
page 10 in the guidelines.
All right.
It's all out of my head.
Uh-huh.
445 in your textbook. Okay, so 445 in your textbook, page 10 in your guidelines. We're talking about key component number 1, and that is history. You have 4 levels of history, and it's not any different than what we've talked about already. Problem-focused, expanded problem-focused, detailed, and comprehensive. Key component number 2 is the exam, and this is the objective exam of the patient. We have 4 levels of the exam as well: problem-focused, expanded problem-focused, detailed, and comprehensive. The third key component is your medical decision making. These are the number of diagnoses or management options and the data to be reviewed, and what are the risks for the encounter to the next visit. So can I let the person go home, or do I have to admit him to the hospital? Then we have the 4 levels of medical decision making. Straightforward, low, moderate, and high. Some of the other factors to be considered when we establish the level of service: again, your contributory factors. What are your contributory factors on page 448 in your textbook? So we just talked about the key components. Now we're talking about the contributory factors. That would be counseling. Counseling is the first one. This is face-to-face. This is where we provide to the patient or family members. We usually discuss the diagnosis, the test results, impressions, recommendations. We might even have medical documentation to support more than 50% of the visit was counseling. Page 448 in the textbook. Coordination of care is face-to-face. This is where the work done is on behalf of the patient by the physician to provide the care. So we might make arrangements for admission to rehab hospital or nursing facility. And then what is the nature of the presenting problem? So what is the type of problem the patient is presenting to the physician with? So what's the foundation upon which the key components are factored? And then we have types of presenting problems on page 449 in your textbook. Minimal, self-limiting, low, and moderate, and high. Your minimal presenting problem might not even require a physician. This is where we might have a dressing change or removal of an uncomplicated suture. The self-limiting presenting problem, this is a minor. This is usually the problem being minor and a good outcome is predicted. Someone with a sore throat or a slightly irritated skin tag. A low presenting problem are usually without treatment, low risk. So someone who's middle-aged, a healthy male with an upper respiratory infection. A moderate presenting problem without treatment or moderate risk. So an elderly male who has pneumonia. A high presenting problem is usually without treatment, a high risk, so an elderly male in very poor health with severe pneumonia. And then time, so direct face-to-face, physician and patient together. So is it at a clinic visit or is it at the bedside in the hospital? You want to use your time-based codes by writing at the beginning when it started. So you came in at 8:08, and when did you end? You finished at 8:48. It must be documented in the medical record. So is the total time spent an indication that it's less than 50% was counseling and coordination of care? When we talk about unit and floor time, usually this is the time that is spent by the physician on the patient's floor or unit, and it also includes the time that he is spending at the bedside. So if that provider walks on the floor at 8 o'clock, the patient's in the hospital, he walks on the floor at 8 o'clock, he goes to the desk, pulls up the record, and starts reviewing the record, but doesn't get in to see the patient until an hour and a half later. That is considered unit and floor time. So then an hour and a half was spent with the record, and then another probably 10 minutes was spent with the patient, right? Yeah. So the physician will just review the records and chart at the desk and then go talk with the patient. So you see on page 451, they give you an example of your CPT book. And it goes over all of those different things that we just talked about. So you have your 3 key components. Then you have the 3 contributing factors. Then you have the number of key components that are required. The place of service, the category of the patient status, the CPT code that's involved. See how small they make it look? Everything we just reviewed is that little picture. So when we use the E&M codes, we're grouping them by type and place of service. So as I said earlier, consultation, office visit, or hospitalization. And we use different codes for the various levels of service. For new patients, we start out with 99201 and go all the way to 99205. And this is for a new patient in the office or other outpatient setting. For an established patient on page 453 in your textbook. When we use a 99211, this might not require a physician. There is no such code in the new patient category that does not use a physician. All new patients are seen by a physician. So that would be a 99201. A hospital observation status on page 455. This is where they are not officially admitted to a hospital. The patient is not ill enough to admit, but they are too ill not to be monitored. You want to read the notes at the beginning of every subsection in your CPT book. Your observation services are not codes for inpatient services. When we talk about an observation admission, it can only be reported for the first day of the service by the admitting physician. And when we admit the patient for observation and discharge them on the same day, we're going to use codes 99234 through 99236, which is your observation or inpatient care service category. Medicare has time constraints for these codes, so you want to be aware of what those are. If a patient is in a hospital overnight for observation less than 48 hours, the first code that you would use would be a 99218 through a 99220, and the second day would be 99217. If the observation stay is longer than 48 hours, the first day would be 99218 through 99220, and the second day would be 99224 through 99226. And then the third day would be 99217. For the initial observation care, this is the beginning of the observation care service. Does not usually require a specific hospital unit. It can actually just be a regular bed anywhere in the hospital, as long as the status is specified as observation. Services are immediately prior to admission bundled into the observation service. So for example, an office visit prior to observation is bundled into the observation service if it is performed on that same date of service. On page 457 in your textbook, your hospital inpatient services are formally the person is admitted to the hospital setting, and then they are in the hospital all day and night on a given date. If it's partial, it would be all day and no night, or all night and no day, or a variation. So you have total inpatient services or partial. A person or patient starting on observation and then being admitted, you would have those services actually bundled into the initial hospital service, and that would fall between the codes 99221 and 99223. On page 459, types of physician status. An attending is a primary or an admitting physician, and a consultant is a physician whose opinion and or advice requested by another physician. Usually a consultant, there is specific criteria that is required. With your types of care, the concurrent care, when we talk about concurrent care, this is given to a patient by more than one physician. So if we have a pulmonologist and a cardiologist who are both treating the same patient for different conditions at the same time. That would be concurrent care. There are two types of hospital inpatient services. The first one is initial. The second is subsequent. The initial hospital care on page 457. The first service would include the admission. The initial hospital care, the first service includes admission. This is where that initial paperwork is done up, the initial plans and orders. It would be used only once for each admission by the admitting physician. Your other physicians would bill the consultation or subsequent hospital care as appropriate. On page 458, the subsequent hospital care. After the initial service, a physician would review the patient's interval progress using documentation and any information that is received from the nursing staff, and then examination of the patient. You would have two of the three key components met. The hospital discharge services are over on page 459. The final day of hospital stay when the patient was in the hospital for more than 1 day. Your documentation would indicate final patient status. Again, hospital discharge services, it would be the final day of the hospital stay when the patient was in the hospital for more than 1 day, and your documentation would indicate the final patient status. And your codes would be based on time. And the time does not need to be continuous. So make sure you put the beginning and ending time, or the total time, and it must be documented. The final status of the patient would be, what's the condition when they left? What medications are you sending them home with? What's the plan for the return to the physician, and how has the hospital stay progressed? Are you discharging them to the house, to their home, or a nursing facility? Unique to discharge codes. Only the attending physician can use a discharge code. And this discharge code is based on time spent in the service. Your consultation codes, they will be on page 460 in your textbook. Your consultation services are your codes from 992. The consultation service codes are from 99241 through 99255. Usually one physician requests another physician's opinion. It can be inpatient or outpatient. When you have a consultation service, there would be a report, and it would be as outpatient or inpatient. You usually have only one consult by a consultant per hospital admission, and again they would provide a report of their opinion and or advice. It would also be documented in the record. Third-party payer consults, make sure that there's a request to confirm any past medical treatment, the current condition. Your payers might even request prior to approving the procedure. When you bill, use the inpatient or outpatient consult codes and make sure you apply the 32 modifier for the mandated service. Outpatient consults are also included in those provided in the emergency department, and as of January 1st, 2010, payment for Medicare consults are no longer reimbursed. You would report them with the E&M codes for an inpatient or an outpatient. Page 466. These are your emergency department services, 99281 through 99288. These would also be codes for new and established patients. They are usually qualified as ED or also known as ER, which is usually open 24 hours a day and you don't have a scheduled visit. It is usually the emergency department staff who provides these services. Your critical care services are usually involved in your ED codes. The ED services often require that additional codes from critical care services are used. So if you have a multiple organ failure, your critical care services provided to patients in life-threatening situations might be of type of breathing apparatus, and your codes are time-based. Usually total time less than 30 minutes would be reported with the appropriate E&M code. Your critical care services, 99291 and 99292. These are used to report the length of time a physician spends caring for the critically ill patient. A 99291 is usually 30 to 74 minutes. 92, each additional 30 minutes, and over 24 months of age is considered an outpatient. Someone over 71 months of age is an inpatient, and if the total time is under 30 minutes, it would be reported with an E&M code. Your nursing facility services are your 99304 through 99318. This is usually continuous healthcare services to patients who are not acutely ill. Then the other categories that you see in your book, you'll see nursing facility. They have care, subsequent discharge, prolonged services, domiciliary, home services. They even have standby service on 473, which is a physician not caring for other patient. You would use code 99360. So your physician's not on call or not available, a standby physician would be the one called. Your case management services, usually used to report coordination of care. Or it could be something like anticoagulant management, outpatient management of Coumadin therapy, or warfarin. Medical team conferences, face-to-face with the patient or family. Gives you the different codes to use. Care plan oversight services. Usually this is used to report supervision of patient care who's in their home or domiciliary. or that type of environment, it would usually be reported for every 30-day period. And usually you report it in increments, time increments. Your preventative medicine, 99381 through 99429. This is usually an annual checkup. Your non-face-to-face usually are codes 99441 through 99449. These might be telephone services or reports that are done online. Your newborn care and neonatal pediatric critical care services, you'll see that they are newborn care, delivery and birthing room, pediatric critical care, inpatient neonatal, and inpatient pediatric. Your initial and continuing intensive care services are the 99477 through 99480. This is hospital care. Your 99477 would be for neonates who are 28 days of age or younger. The 99478 through 99480 is divided by the birth weight. You might have very low birth weight or low birth weight or normal birth weight. And then other E&M services would be 99499. And this would be used very rarely. And if it is, you want to make sure you have a written report upon submission. Now, I mentioned earlier about the guidelines, 1995 guidelines. You'll see on page 482, they have documentation guidelines and history of the development of guidelines. This is what I was talking about. Let's take a good 5-minute break here, and then we'll come back and we'll do the theory and review and practical in the end of chapter 15, go into the workbook. And I do want to get to some of the anesthesia reports before we have to break for the night. So 5 minutes, please.
I had a question. So everything that we just reviewed, is that like toward the scoring system of what you're going to look up?
What do you mean?
So, like the key... Hold on, I'm back here. Like when we do the examination elements and stuff, does that go, like the ones that we just went through for the review of the systems, does that go through like your expanded problem focus? That's where you're going to find that information? You pick all that stuff out?
Yeah.
Okay, that's where it was confusing me. I see all this information, but I didn't know what to do with it. That's actually going to be part of my elements.
Yes.
Okay. Yes. That just helped a little.
Good. Yeah,
So
it looks
you
like a
actually
lot
use...
of information, but we'll teach you how to use it.
Okay, all right. Just that gives me an idea of where I'm
Good.
at. Like I said, I thought I had to break down each section into all them sections.
No.
And it was. I'm like, okay, how do you get all these things put together?
No.
Too much.
Pete, did you get her bed ready? Yeah. That was nice of Papa. Are you coming in with me? You're gonna have to lay down. You know, if you're having a lot of questions, maybe you and I can get together and go meet her on a weekend.
Yeah, it's a lot.
I mean, I don't know where you live. I live in West Gardner. Not just
Yeah,
about the
actually,
road.
I'm just outside of Gardner. She said Saturday that we could do a voice get together. I don't know
I
what she
like
means by that.
face to face is better.
I do. That's why I'm gonna go actually to the class next week.
You are.
Find out where it's at.
So, isn't she all the way in Saco?
No, it's in Brunswick. I think Mount. What is it? Mount.
She's from Saco.
Yeah, but they're actually in Brunswick because they've been having to verify it. Let me see where the things at. Is Mount Ararat the Brunswick High School? Yeah, because it's Mount Ararat High School.
Yeah. That's Brunswick.
That's what I assume. I'm hoping. It's worth traveling the next few classes. Too visual. I have to see it, perceive it, read it.
My book is tabbed on your CPT. On the whole bottom, I tabbed all the numbers of what it was starting with each section. Like 0, 1, then 10s, 20s,
Oh, that's
30s,
a good idea.
35s, 40s.
That's probably what she's going to show at the end of the class. She said she's going to show us her book.
Yeah, I think I'm an over tabber, but I have bottom, top, and side tab in my CPC book. This is my second time taking this class.
Well, I see, I did it through Helping Hands, and this is my second time. I went back to my CNA stuff. And I don't want to blow it off again. It's just, I've got to learn it.
Yeah, and you remember it when she's talking about it, but geez, there's so much to remember.
Yeah, and
Keep
all
telling
day,
myself.
like I said, yeah,
When
that's
I get a job, when
like
I
at the
get
end
a
of the-
job, you're not going to have to know all of it,
No,
you know. It's
that
just,
test is what.
That's what
Because
killed
I'm
me,
doing
that-
both.
huh?
I'm doing the medical terminology and the billing right now.
I did anatomy, physiology, medical terminology, this certified medical administrative assistant, and medical billing and coding.
Wow, that's a lot. I'd
Yeah.
love to do the hospital next, though. I really would, but it's going to be a lot more. You can tell.
I think it'll be easier. That's the test, 5 hours and 40 minutes long. But she's going to do
Yeah.
a mock one, so that would be good.
Yeah. Phew. I know after an hour, I'm like, ugh.
You know what? When I took the test, when I took it, it went by so fast that 30 minutes, they said 30 minutes. I'm like, 30 minutes? I'm not done yet. You
Yeah,
know?
it does stress the test the
I started
anxiety.
just filling in the dots, and I failed it.
Ugh.
Yeah,
I know, that's
didn't
what I
pass
worry
it.
about. It's a lot of memorization.
Yeah, but we keep being told not to memorize.
I know. How can you not? There's so much there. You have to. You have to know the steps to memorize
It's a
what to
puzzle.
use to get there.
No, I have my book coded to the way when I took the class the first time, and hers aren't coded. Hers aren't tabbed like my books.
Yeah. And like I said, I definitely want to come in. That's for sure. I got to be there. It's just easier.
You're gonna drive there every week.
Yeah. Well, how many weeks we got left? Not much.
Quite a few.
What,
We're only
when's it end?
We're only in chapter 15.
I
And
thought we were like halfway through February we were done.
no.
No.
We have 28, 31 chapters.
Yeah, we're on 15 though. We're already halfway there.
So a chapter a week, you figure.
Yeah.
Can't be that long.
We'll have to ask
we,
her.
I thought we got out in April or so and took our exam in May.
Huh.
I don't know.
Because out the next,
Here she
we'll have
comes.
to ask. I totally screwed that one up if we did.
Yeah.
I decided
When's
to come
that?
back, ladies.
When's our graduation date?
What graduation?
When's the last class date?
Well, we're on week 12, so what do we have?
We're on week 15.
8 more classes? 8 more classes? And we have a break in there for school for what, February? So what is it, middle of March?
Oh, yeah.
I'm going to be gone 1 week in February and 1 week in March. March, I'm going to Florida. Exciting.
All right. All right, let's do the chapter review and practical. I'm assuming everyone can hear me okay?
Yeah.
Good. Because I don't like to yell.
Me neither.
Doreen,
Yes.
could you send me this one again for the video? Could you
Yeah.
send it to me? Thanks.
All right, so theory. Number 1 is total. Number 2, it begins preparing the patient to receive anesthesia. Or, I'm sorry, I'm on the wrong
I said
chapter.
you're reading.
And I have my glasses on. And they're new. I think they gave me the wrong prescription. Okay?
Doesn't help with tiredness.
No. And I just realized I have my pen on my shirt from work today. I forgot to leave it on my desk.
Lucky pin.
So, number 1 is body area. Number 2, new, established, inpatient, and outpatient in any order. 3, initial and subsequent. 4, status, type of service, and place of service in any order. 4 is the number 4. 5, you would have expanded problem focused. No, hold on. Back up.
I was going to say, I had
Okay.
patient. What was it?
3 is initial and subsequent. Okay? 4 is status, type of service, and place of service.
Yeah.
Number 5 is the number 4. And 6 is expanded problem focus. 7, problem focused. Expanded problem focused. Detailed and comprehensive. 8, problem focused. 9, very low birth weight. 10, straightforward. And 11, inpatient. Number 12. How many did the homework?
I didn't. I just had no idea.
Okay. And how about you, Lisa?
I did some, but it was more of what you just did than this back end of it.
Okay. So I'm going to do a couple of the even numbers, and then I'm going to leave you to do the rest for homework so that you have the practice. And then we'll go over the answers next week, or if you want to, Emily, email me and I'll send you the answers, and you can check them. So let's look at number 12.
Can I just ask a question?
Sure.
When we're done doing this, before we go, I have a couple questions about the workbook homework. I just don't want to forget.
Number 12. Physician provides initial intensive care service for the E&M of a critically ill newborn, 5 days old, inpatient for 1 day. Well, we know that they are 5 days old. It's an inpatient. If they're 5 days old, they're going to be what? A neonate.
Neonate.
So we want, because it says initial intensive care services, we want neonatal critical care. So it's an E&M for neonatal critical care. So look up evaluation and management in the index in your CPT book. And try to turn your pages quietly, because online students still complain they can't hear anything. Or mute your mic. So if we go to evaluation and management in the index in our CPT book, we should end up on page 808 in the index. Then we're going to go to neonatal critical care over in the third column about midway. It gives us codes 99468 through 99469. So we would then go to that section in our tabular, and I don't have my book tabbed yet, so it's going to be a pain in the butt. We're going to look up those codes. And actually, remember, it falls under the E&M section, not in the tabular. So 99468, 99468 ends up being on, starts on page 41, and you end up in 42, 43, 44. Guess what? I have a lot of reading to do in there because there's a lot of notes. All right, on page 41 in the E&M section of your CPT book, you start with inpatient neonatal intensive care services and pediatric and neonatal critical care services. Well, when you're sitting for the national exam is not the time to be reading this. Okay? You want to be reading it now as you're doing your homework and assignments and highlighting things that you need to know. Stuff that sticks out for you. Okay? That's why I say have your textbook and your CPT book side by side so you can make the notes in your CPT book as well. So 99466 and 69, 68 and 69 on page 44, 99468, initial inpatient neonatal critical care per day for the evaluation and management of a critically ill neonate, 28 days of age, 28 days of age or younger. And then 99469 is actually subsequent inpatient. Well, the exercise says initial intensive care service. So 99468 would be the correct code. 99468. Okay, let's do number 14. Number 14 is a 68-year-old woman. She visits her internist again, complaining of angina that seems to have worsened over the past 3 days. The patient had an acute anterior wall myocardial infarction 2 months earlier. 1 month after the acute MI, she began to have angina pectoris. The patient also states that she thinks the medications are causing her to have gastrointestinal problems while not relieving her symptoms. She had refused a cardiac catheterization after her MI to evaluate the extent of her coronary artery disease. The physician performs a detailed history and a detailed physical exam of her cardiovascular, respiratory, and gastrointestinal system. The physician indicates that the decision-making process is moderately complex, given the number of conditions it is necessary to consider. Now, that's a lot of what I call gobbledygook to come up with the one code, But what you have to understand here is that we are only looking for the CPT code. We're not looking for any of the diagnosis codes yet. Okay? So what is the key term here, or what you want to focus on, is that she is a 68-year-old woman who is visiting her internist again. Okay? And then whatever it is she's complaining of. So if she's visiting again, that means that she is an established patient. Now they tell you that they are doing a detailed physical and a detailed history, right? And then they go on to tell you that the medical decision making is what? Moderate. Guess what? They just did the homework for you.
They wrote it all up.
They gave you 2 of the 3 because you need to have 2 of the 3. So they told you it was detailed. When you have the level of service higher than what? You are going to go towards that level. So if you have 2 detailed, you're going to go to a detailed E&M. If you have a detailed and a moderate, you're going to go to a moderate. Whatever the 2 of the 3 are, that is the level you go to. And the majority of the time they will tell you what those are. Okay? So, you're going to look up evaluation and management, office and other patient for a detailed visit. Look that up and then tell me what you get.
Not under an established patient.
That's what the code is.
Right. Oh, okay, and then I have that right.
1 minute, I'll ask all of you. So while you guys are looking for your codes, as I said earlier, when you're reading in the ICD-9 book, you want to do the same thing in your CPT book. Read the before, read the middle, during the after, read the after. Read the coding tips, read the colored text. Just like you read the categories in your ICD-9 book, read the categories in your CPT book. Because this chapter, your E&M chapter, is the foundation for all of the other codes that we're going to be learning. You go in for an E&M, and then they add the other stuff on top of it. Okay?
So are we looking under the new and established patient?
You
from
are
what-
looking under outpatient services.
Outpatient.
Office and other outpatient services. And it's an E&M for an office and other outpatient.
The TV, but I'm not finding.
What did you get, Lisa?
99214.
Emily? 99214. Angel?
I thought it was 99213, but
Okay.
now I'm looking at it, it's not.
Right.
Because
Because it says
usually
expanded,
presenting.
right?
Yeah, it said usually the presenting problems are of low to moderate severity down
Right.
in the
But
bottom
if you
left.
look at 99213, in those three bold areas, it tells you expanded. In 99214, in the three bold areas, it tells you detailed. Detailed.
Okay.
Okay? So you want to pay attention to the level of exams. Is it problem focused? Is it expanded? Is it detailed? Is it comprehensive? Okay? So they told you right in the exercise it was detailed history, detailed exam, and a moderate medical decision making. So 99214 is the correct answer.
And so that made your three key components because they used those three.
Yes.
And okay.
And we'll get into more detail about the components because we're looking at two of the three types of history exam and medical decision making. So what was the history? What made up the history? What made up the exam? And then what made up the medical decision making? So when I say two of the three, we need to know that two of those three items, three factors, two were higher than another. That's what I mean. All right, let's try 16. And I'm not going to worry about diagnosis codes right now. I just want to work on E&M codes, okay? But if you didn't do the diagnosis codes, do try and do them later. So 16, an established patient, okay? They tell you right there, it's an established patient who is admitted on observation status. So we know we're going to look for an evaluation and management for hospital services, observation, initial service. Status for influenza symptoms, extreme nausea and vomiting. The patient is dehydrated and has been experiencing dizziness and mental confusion for the past 2 days. Prior to this episode, the patient was well but became acutely ill overnight with these symptoms. Given the abrupt onset of these symptoms, the physician has to consider multiple possible causes and order a variety of laboratory tests to be performed. The patient is at risk for a moderate number of complications. The MDM is moderate, comprehensive history, and a comprehensive exam. Okay? So we want to go to evaluation and management in the index, and we want to be looking at hospital services and it's an observation service.
It's on page 14.
And it's really pretty simple because they give you 3 to choose from, but they told you right in the exercise, comprehensive, comprehensive, and moderate. So if you look for those key words, you should have chosen 99219.
9.
Now, for the diagnosis codes. Well, they have extreme nausea and vomiting. So they have nausea with vomiting. That's your first diagnosis. The patient is dehydrated and has been experiencing dizziness. Dizziness is the next one. Mental confusion. Confusion would be the next one. And then dehydration. Because all of those things cause the dehydration. It's not the dehydration that caused those things. Okay? So you should end up with 4 diagnoses there.
I have such a hard time telling them that with the dizziness.
Yep.
Because, you know what I mean?
Yep.
You could-
Right. So those are the things I would have you look up. Nausea with vomiting, dizziness, confusion, and dehydration. Okay, so you can look those up for homework. Let's look at number 18. 18 is an 8-month-old infant who is a new patient. Is brought in by mother for diaper rash. The physician focuses on the problem of the diaper rash for a problem-focused history and exam, and the complexity is straightforward. This is pretty simple. It's an E&M, office, and other outpatient. New patient tells you right away it's going to be a new patient, so you would look underneath the new patient section. And when they tell you problem focus, it's usually an indication that it's an O1 or an O2.
Two. 99201.
So for this one, you should come up with a 99201.
Yes.
And then the only thing you're going to code here for a diagnosis would be the diaper rash. All right, let's go into your workbook. Did any of you do the theory?
Wait.
Okay, let's do the theory.
Yes.
Number 2 is F. Number 2 is F. 4 is G. 6 is D. 8 is H. The 4 types of medical decision making in order of complexity from the most to the least would be high, moderate, low, straightforward, and elements. 5 types of presenting problems: high, moderate, low severity, self-limited and minor, and minimal. 19, contributory. 20, face-to-face or direct or unit and floor. 21, medical record. 22, counseling. 23, subjective. 24, emergency. 25, consultation and attending. 26, critical care. 27, concurrent. 28, transfer of care. 29, review of systems. And 30, no. $31. Minimal or minimal and none. B, minimal. And 31C, straightforward. And D, 99201.
$32 is the one I have a question on.
Okay, what's your question?
Well, the CPT code, I got 99217, but the ICD-9 came up with a V code,
Yep.
and I couldn't figure what to put next to it because I just couldn't find it in the paragraph.
Okay. So he was admitted for what?
For getting in a car accident with a subdural hematoma.
Okay. So if
They
they're
thought.
okay, your key word here is observation status. So when they're admitted for observation status, it's going to be admission first. Remember your V codes. Then observation status. And what was the observation status for? It was because of the accident. Go try that, Lisa, and tell me what you come up with. So observation for admission for observation of accident. Try that.
Admission for observation. Observation care.
So admission for observation accident.
But I still am like really confused. 99218. I have 99217.
99217 is correct, but
Okay.
your V code is
It's
for the
not.
admission, for observation, accident.
Point 4. Observation following other accident. There wouldn't be an other. It'd be one of the accidents. I mean, it says
Just
other.
accident.
So don't do the 7.1.4.
That would be correct. 71.4.
Okay, but then what do you put in the next code?
It's an E code.
Oh, I gotta find
For the
out.
accident.
The E codes just I don't know why I have a hard time with the E codes. I think it's because I have to go through it and find it.
Well, go into the E code index, and then
Yes.
we start with accident.
Well, I gotta find
With
it first.
accident. So page 1764. And what type of accident is it? It is a motor
17
vehicle accident, right?
My E codes aren't that high.
No, the page number.
Okay, say it again.
Page 1764.
Oh yes, back here. This is where I forget. This is why I was having such a hard time with that. I forget this back here. Okay.
And then motor vehicle is on page 1766. So we see motor vehicle, and it tells us to go to E819. So if
Yeah.
we go to E819 in the E codes,
E8.
E819 on page 816 in the E code tabular tells us it's a motor vehicle non-traffic accident. It gives us the subclassification or the subdivision, and we choose E819.9.
Okay. So
So
the V code comes first.
The V code comes first. Your E code is never primary. Your E code is never primary.
Yeah, I have a big thing that says don't code first written on it. Thank you very much.
You're welcome. All right. Let's see. So then the workbook, you didn't do the workbook either, right?
I did.
Ingo?
No, I haven't. That as far as I've went is the first one, and like I said, I got that out of the back of the book, trying to figure it
Okay.
out. It just wasn't happening. I
Okay.
understand a little more now that you've
All right.
explained it.
I didn't
So
get it
what-
all done, but up to 50, question 50.
Okay. So let's look at number 34, and let's pick out the what we would be looking at, okay? And I'll send you guys home with this to finish. And then if you want the answers before next week, email me and I'll send you the answers. And then that way we can go over next week in class, maybe for the first half hour, answer any E&M questions you have, okay? So for 34, this, what gives us away here is that the 16-year-old female is being admitted by her family practice physician. So 34 is going to be admission, right? Admission for what? To the hospital. So it's an inpatient. So hospital services, inpatient services, inpatient hospital or initial hospital care. Comprehensive history, detailed exam, so we're going to look up under hospital services. It's an inpatient, and it's initial care. What do you have for that one, Emily?
I haven't gotten it, I'm sorry.
Okay. What do you have, Angel?
I had 99221.
That's correct. Lisa, do you concur?
Yep.
Now,
Got it.
if I had a question, like I know that's the initial code, when they come in, but like if they stay more than that one day for observation and stuff, do you code the next one
There
for like
are,
the subsequent hospital care? Would you do that for the following
It would
days that they were there?
there would be subsequent codes, yes.
Okay.
So you would have to pay attention to the documentation. All right, so let's take a look at the board. Can you ladies online see it okay?
Yep, great.
All right, so we talked about early on in the class when we're billing, how all of our codes tell a story. I don't have any diagnosis codes up here, but you'll see when we start putting things together in the exercises, just the few that we've done tonight. We have some diagnoses and some CPT codes. So for a new patient, right here, we have 99203 with a modifier 25, a 98940, a 98943 with a modifier 59, and a 72100 with a modifier 26. What we're telling the insurance company is that we have seen a new patient for a level 3 exam. And our modifier 25 is telling the insurance that this is a distinct separate service. Or separately, okay? 98940 is a chiropractic manipulation to the 1 and 2 regions. The 98943 with a modifier 59 is an extremity adjustment. So we show a 59 modifier to show that that was a separate, distinct procedure. This was a separate, identifiable procedure. This is separate, distinct. All right? If you look in the terminology, you'll see what I mean. The 72100 with a modifier 26 is an X-ray. Okay? A modifier 26 is basically telling the insurance that the provider read the X-ray. Over here in the right-hand column is an established patient. A 99213 with a modifier 25 is telling the insurance this is a level 3 E&M. So all of what you learned tonight, what are the key components? What are the contributing factors? What's the past family social history? What's the chief complaint? 98941, same as the new. It's a chiropractic adjustment, 1 to 2 regions. So it could be low back and mid back. 98943, extremity adjustment, extra spinal manipulation is an extremity. So arm, elbow, hand, foot, knee. And then the X-ray, 72100 with the modifier 26. This is as simple as it is. But you read the documentation that we have in our exercises to create this. That's what we're learning here in this class, is to take what we have on paper, what you read in your exercises, and make a claim.
And make it so the computer can read it.
Yes. Yes. Because all of the software programs have a place for you to put it. And some programs are so specific that they have all of the required boxes with a little red box next to it that indicates what part on the CMS 1500 form it relates to. So you know what needs to be filled out when you are entering the data in the system. Okay? So this is what we're learning here. And then when you add the diagnosis codes and you put the diagnosis pointer with the code to match it up to the procedure code, okay, on the claim form. All right, that's what this is all about. Okay? So, let's go on to 36. Actually, we just did that one, right? Mm-hmm. No, 36.
34.
We just did 34. Let's do 36. The patient is a 34-year-old established patient. So if they're an established patient, we know that we're going to look in the 99211, 12, 13, 14, or 15. It is office or other outpatient. So E&M, office and other outpatient, they tell you that it's a detailed history and exam. What did you have for this one, Emily?
9953.
Okay. Evaluation and management, office and other outpatient,
Sorry. 99.
detailed history and exam,
I'm not gonna write it down. 99243.
office and other outpatient. So it's an established patient,
Yeah.
office and other outpatient services, page 14. You just went too far. So that's what will mess you up in the E&M service if you don't pay attention to the categories. So this was an office and other outpatient visit. You should have a 99214. Established patient. She saw the dermatologist in the clinic. Okay? So it wouldn't be observation or, all right? It's other office and other outpatient. And then the diagnoses that we would choose are we would first look up psoriasis and then joint pain or pain in the joints. So I think I pointed out last time that in your workbook, pay attention to the headings in bold. Because the next page on page 86, it tells you consultation services. So you want to make sure you're looking under your consultation services for your codes. Now, that means that you start in the alphabetic index first and then come back in the tabular to confirm them. So number 40 would be a consultation. Office and other outpatient. She was sent by her family practice physician for an office consultation with a gynecologist. And her diagnosis would be pain. What type of pain? Would be chronic. And why would it be chronic? Because it's due to trauma.
I think I'm going brain dead. Oh, sorry.
It's okay.
I didn't mean to say that out loud.
That's what I was saying last night. I think my book has a few more wrinkles from throwing it aside a few times.
If my book could talk, we'd all be in trouble.
So we got 2 of 3.
I got it. I found it.
What did you get?
I got 99253.
No.
Oh, I must be in the wrong place.
It's consultation.
Yeah. It's not
Office.
inpatient. It would be outpatient.
Right.
That's what I did wrong.
So under consultation, it would be outpatient.
So 99241.
Keep going.
2?
It was a detailed or comprehensive. What is it?
Comprehensive, because it has 2 and then
Right, it doesn't have them all because complexity is moderate. And then that
but
is
there's 2 comprehensives. They
Right.
outnumber the moderate.
There you go. So it's 99244.
I don't see how, because it's a detailed and a detailed.
Detailed physical exam.
Yeah.
Medical decision making is low. High fever, pelvic history, present illness. Okay, they did a review of systems. They found positive responses in 5 of the 12 body systems. There was a negative medical history related to urinary symptoms, detailed physical exam, gastrointestinal system. So even though the
You don't go with the 4-3?
no,
So we'd only be looking at the medical decisions of moderate complexity and not the other 2
right,
on the 4-4. And that's because of what is read underneath it.
right.
Okay. I would have got that totally wrong. I did.
All right. So, Lisa, did you have other questions in the workbook?
Yeah.
Which ones?
I gotta find it.
Angel, how about you?
I didn't get that
Yeah.
far.
Okay.
I'll do them tonight.
Number 42.
All right,
Finding the
42.
CPT code. Yeah.
42 is a new patient,
Yeah. I
but
don't know
it's
why.
an inpatient because they were admitted to the hospital.
That's why.
So new patient,
Okay.
new patient, inpatient. It's an inpatient consult. Because it says
Okay.
patient is seen in an initial patient consultation. Expanded problem focus history and exam.
So it's a 99252.
Yes.
Wait, I might have one more.
Okay, Emily, did you have any?
Number 45. I do all of them, not just because it's just easier.
That's fine. I just the odd number answers are in the back of the book.
Oh, I didn't even look in the back of the book. All right,
The odd,
that's
the
all right
odd
then.
number answers are in the back of the book. So with
That's
45,
funny.
it's a hospital inpatient service.
Yeah. Hospital inpatient, not consultation.
Which one are you looking at?
45.
45. Inpatient hospital care. This problem. Focused. Detail.
Well, I had
And
more than a headache. They didn't admit me.
And this is a subsequent because it says subsequently seen.
Yeah, you only need 2, right? Yeah. I go out in front of all mine and write how many I need so I don't have to look back.
That's fine.
Make it easier for myself. Problem focused. 99231.
Yes.
See, I was totally wrong here on mine. That's why I had the little. I only made it to 50, so those are
Okay.
what I had questions on.
All right, so finish them up. Your odd numbers are in the back of the book. What I suggest if you do all of them, check your odd numbers in the back of the book. Again, don't erase your answers. Cross them out and put the correct one next to it. And then if you really can't figure out why, then let's talk about it next week. But for homework, besides the E&Ms, you should be chapter 16 and 17, which is anesthesia and surgery. Again, I want you to do the review and practical at the end of the chapter and do the even numbers in the workbook. Okay? Again, do as much as you can. If you want the answers to everything before class, just email me and I will send you them. But please tell me which chapters. Okay? I'm not a mind reader, and with 100+ students in 2 different courses, I do not remember who is on what chapter in what course. So in the subject line, it's really helpful to put CMAA or coding and then what chapter, and maybe, in the body put what you want. Okay? That honestly is the most helpful for me. Pretty please and thank you. Emily, what is your takeaway from tonight?
I have my alphabetic index in this ebook.
Yes. All right, so let's talk about that. I'll show you real quick, and I don't know how well everyone's going to be able to see this. All right. Can everyone see that?
Yep.
Is it too far away?
I have mine a little
What's
different
the
than
white
that.
ones have on it? The white tabs?
The white tabs are the numbers.
And what are the numbers clarifying?
They correspond to the section of the CPT book. So your 1 is your surgery. Your 2 happens to be musculoskeletal. 3 is the respiratory system. 4 is the digestive system. 5 is the urinary system. 6 is the nervous system. Okay? Because as I said in the ICD-9 book, we're going to be looking up codes. So if you know that you're going to be looking up the code in the 6,000s or the 7,000s or the 1,000s, that makes it easier than trying to remember that I'm going into the nervous system.
So them are the review of systems that you tabbed.
Say that again.
Those the numbers are the review of systems that are in the front of the book.
No, the numbers
No? Okay.
are each system in the book.
Okay, each system in the book.
And as I said, you have little tabs in the front of the book that they give you that already tells you which system. Okay? So what I did was I put the system and then I put the corresponding number. Honestly, I don't look at the system. I look for the number. When I'm coding, I look for the number. Okay? I'll take a picture with my cell phone and I'll post it on Evolve underneath this week or chapter 15, okay? Any last minute takeaways, Angel?
No, just got to pay a lot of attention. Just a lot of memorization for categories.
Okay, Lisa?
I gotta read more before I jump at the answer.
Yes. Yes, yes, yes. All right. Have a great week, ladies. Thank you very much for your time tonight. And Angel, if you don't want to come this far, and Lisa, we can schedule a conference chat, a video chat through my house. We can just do it on a Saturday or something, or whatever.
Okay.
Now, does it go through the Evolve, or how would we get on to chat together, or where?
Do you have
How would you
Skype?
go? Yeah.
Lisa, do you have Skype?
Yes, I do.
Okay, we can try to do a Skype.
What
not,
are you going
I
to send
can-
us the time? What time
Well,
would be
what time
good?
works best for you guys? Because Saturday, I'm actually gone all day this Saturday. So,
Yeah, and I work on Sundays.
okay. How about
Every 5th Sunday, which is this week.
Monday nights?
That works.
That works for me.
After 6,
Okay.
so my husband's home. I
Okay.
have a 2-year-old and a 6-month-old.
So how about Monday night at 7?
Works good.
Okay.
You
Send me an
just gonna
email
come
to
on to
remind me,
Monday?
please. I'll send you an email invite with a link to so we can do a meeting.
Okay, so Monday night, what time did you say?
7 p.m.
Okay, thank you.
All right. Thanks, ladies.
All right, thanks.
Bye.
All right. Bye.